5.
Good morning, everybody. I'm Jesse Powell, and I'm pleased to welcome you to another session of Medical Grand Rounds for the Portland region. And this morning we're having the celebrating the Gilbert Lipschutz Memorial Lectureship. Dr. Lipschutz was a well-known and beloved physician in our community, known for his skill, his commitment, humor, dedication that he brought to the practice of medicine. And since 1998, Providence Portland Medical Center has hosted this lectureship to celebrate those intangible skills that make a physician more than a provider, but a true healer. This lectureship focuses on humanities, ethics, and medical skills. And I'm extremely pleased to welcome our guest speaker this morning, Dr. James Rucker. One of the perhaps few but unmistakable benefits of the pandemic has been the facilitation of virtual conferences, allowing us to bring in remote speakers, bring in quotation marks, of course, but to have remote speakers join us. And today, Dr. Rucker is joining us all the way from England, London, I believe. And we've invited him to speak about a topic that you are all aware of and interested in, which is the use of psilocybin for medical reasons and for therapeutic benefit. As you know, Oregon legalized or Oregon ballot measure 109 allows the use of psychedelic drug psilocybin in supervised facilities. That was a bill that was passed in 2020 and will go live after a 2-year development period, which ends this December. So in 2023, there's going to be implementation of the law and use of therapeutic psychedelics. And so we've invited Dr. Rucker here to speak to us as an expert in this field. Dr. Rucker qualified in medicine at the University College London in 2003. He joined King's College London as a junior psychiatric trainee in 2005 and completed a PhD in psychiatric genetics. He was awarded an NIHR Clinician Scientist Fellowship in 2017 to investigate the safety and efficacy of psilocybin in a controlled setting. And he co-leads the Psychedelic Trials Group at the Center for Affective Disorders. Part of his main academic expertise is in novel psychopharmacological approaches in resistant forms of depression and related conditions, as well as clinical trials in drug-assisted forms of psychotherapy, including the use of psychedelics, MDMA, ketamine, cannabinoids to treat mental health conditions. It's really an honor to have Dr. Rucker join us. I'll be moderating questions at the end. And Dr. Rucker, I'll turn it to you. Thank you for joining us.
A pleasure, Jesse, and many thanks for the invitation. It's an honor to speak to you all today. So I'm talking to you from sunny London, 3 o'clock here. I found myself sort of catapulted into this position of testing psilocybin therapy as a treatment for depression, but my broader interest as a clinician has always been treatment for resistant depression, the people who don't get better and how we can help them. So I've come at this from that perspective. I'm aware of the change of the law in Oregon, not quite sure what I think about it, and my route through this really is quite traditional insofar as we're testing psilocybin therapy in the established way that all drugs and new therapies are tested via the FDA and its equivalents around the world through the clinical trials process. So that's what I'm going to talk to you a bit about today. Also a bit about treatment-resistant depression, why it's a problem, just refresh our knowledge about that, and also some of the history of psychedelic therapy, because it goes back quite a long way, and it's important to understand that history when you consider where we are now. Okay, so just some disclosures by me. I'm employed by the university. My salary is paid by the UK taxpayer. I work in the NHS, but I do advisory work for various companies who are interested in this field. Don't have any investments or shareholdings, and I have various grants that are held by King's College London here, in which we use to do our research, and I will tell you about some of those, a couple of those trials today. This is what we're going to do. I'm going to go, I may skip some of it just to keep to time. I'm aware that we need to leave some time for questions, but this is what I hope to go through. I'm going to concentrate on some of the clinical trials that we have recently completed, and then think about some of the pitfalls of these trials and psilocybin therapy in general, given the historical context and the way that this field tends to sort of polarize opinions. But just a quick reminder of treatment-resistant depression. The definition of this varies, but tends to be a failure to respond to 2 antidepressants. The problem is that it's common. About 10 to 30% of people with major depressive disorder become treatment resistant according to this definition, and the problem with that is that depression itself is incredibly common and burdensome, both to people, carers, and to wider society. And an example of that is that if you have a diagnosis of major depression, then statistically you're about 21 times more likely to commit suicide than your non-depressed equivalent. So big problem for society, not just suicide of course, but other various correlates of poor mental health on physical health, socioeconomic activity, etc. And this is why governments are concerned about it, even though historically, of course, mental health does not get the sort of funding that it really needs. Some of the comorbidities with TRD, you're probably much aware of these, very comorbid with anxiety, suicide risk, that sort of thing. So TRD is a big problem. One of the issues that we have in treatment is that if you have early childhood trauma, then you are much less likely to respond to established treatments. So this is the iSpot-D trial, published back in 2016, that stratified responders and remitters between those who did not report childhood abuse at the age of 4 to 7 and those that did, and you can see that the rates of response and remission to treatment are startlingly different between those who did not suffer abuse and those who suffer abuse. So there's something about the etiology of treatment-resistant depression that may be important in understanding what new treatments we need to develop. And one wonders whether drug-catalyzed forms of psychotherapy may be useful in this group that historically do not respond well to established treatments. That's just a hypothesis, but one that we're interested to test in clinical trials. And we need to do that because, as I say, TRD is common and we rapidly run out of options with antidepressant treatments. There are lots of Me Too drugs around, but they're all sort of variations on theme, and generally speaking, if someone fails a couple of SSRIs, they're unlikely to respond to another one. We can switch, we can add on, but we quite rapidly run out of novel mechanisms of action to try, and then we're getting into the realms of lithium, ECT, RTMS, which have problems of their own. So developing new strings to our pharmaceutical or therapeutic bow is an important area of research, and one, as I say, that has formed and forged my career. We know that psychotherapy in combination with drugs works well for treatment-resistant depression. So studies showing that you're about 3 times more likely to respond or remit if you have psychotherapy in addition to your antidepressant. And also we know that if you give people what they want, then they are more likely to get better than if you give them something they don't want. So this is a trial that stratifies people according to their preferred treatment, randomizes them to medication, psychotherapy and combination, and then looks at response rates, remission rates, according to the type of treatment they received. So if you wanted medication and you received medication, you're more likely to get better with medication, the same with psychotherapy. Makes sense, really, but of course we're not often in a position to do that. You might be more in the States, but in the UK we're less so. So do people want psilocybin therapy? The question, which you might assume the answer to which was no because of the stigma, but actually in a recent nationwide survey in the UK, 59% of people surveyed would consider psilocybin assisted therapy for themselves if they had a condition where there was strong evidence it could be effective. Quite a surprising figure to me. This was also a survey about research restrictions in the UK, of which many people support the relaxation of. So perhaps this is indicative of a sort of change in the air surrounding drugs that have hitherto been stigmatized, criminalized, etc. But there does seem to be an appetite from the public to explore it. So what is this paradigm of psilocybin assisted therapy? A few things to understand. Firstly, don't concentrate too much on the drug. This is a drug treatment embedded in an ongoing process of psychotherapy, and I think the psychotherapy is predominant here. The drug is given intermittently, never given daily, not given to take home, delivered in a hospital setting. So it's an intermittent drug treatment embedded in the process of therapy, and that is the way it was used prior to, in the UK, the 71 Misuse Drugs Act, in the US, the 1968 Controlled Substances Act, which essentially banned all clinical use of psilocybin, LSD, and related compounds. So what we're doing now is basically very similar to what we were doing back then, although with the caveat clinical trials have to be a lot more controlled. Just quickly to cover the different psychedelics, we're principally interested in psilocybin. It was actually LSD and mescaline that were used principally prior to Prohibition, around 1970. There's also some interest in the use of dimethyltryptamine at the moment. Again, there's a sort of drug-catalyzed form of psychotherapy. So we seem to have switched from the phenethylamines and the ergolides to the tryptamines. Regardless, they all do the same thing, which is induce this dreamlike state. One of the participants in our trials described it as like a waking dream. But what's different from a dream is that you can remember what's happened. You generally retain insight into what's going on. And we wonder whether that might be an adjunct or a window of opportunity in the context of ongoing psychotherapy and a safe and supportive context of delivery. So this is a trial that we completed and published a couple of months ago now, largest ever RCT of psilocybin in healthy volunteers. I'll tell you a bit more about it later, but this is the results from a scale called the 11 Dimensions Altered State of Consciousness questionnaire, and you can see those 11 dimensions plotted around the circle here, the extent to which participants rate those dimensions under psilocybin 25 milligrams in blue, psilocybin 10 milligrams in orange, when you subtract the placebo effect. So you can see, as you might expect, audiovisual synesthesia, blissful states, complex imagery, insightfulness, spiritual experiences, all getting rated quite significantly highly, but not so much anxiety, impaired control, and cognition and disembodiment, which distinguishes these drugs a bit from ketamine, which has a similar mechanism of action but different in a way, but tends to result in more dissociation and disembodiment. Why does this effect happen? It's a functionally selective effect on the 5-HT2A receptor. I say functionally selective because not all 5-HT2A agonists cause psychedelic effects. So it is something about the precise conformational changes in the 5-HT2A receptor that mediates the subjective effects under psilocybin, LSD, etc. We know it is the 2A receptor that is principally responsible for the subjective experience. That might not be related to the antidepressant effect, of course, but for the subjective experience, it's the 2A receptor that's doing the job. And we know that because if you give participants a 2A antagonist and a psychedelic, they don't They can't distinguish that from a placebo. And also the potency of different psychedelic drugs correlates very tightly with the affinity or the stickiness of the drug at the 5-HT2A receptor. We also know from more modern studies using PET neuroimaging that the occupancy of the 5-HT2A receptor as measured by PET is tightly correlated with concentration of, in this case, psilocin, which is the active metabolite of psilocybin. And this is tightly correlated to people's subjective, the subjective intensity of effects. So it's the 2A receptor, and this 2A receptor is predominantly located in the neocortex, particularly in layer 5 of the neocortex, but particularly in regions of the brain that are interesting in terms of depression, the anterior and posterior cingulate, for example, but also in the visual association cortices in the occipital lobe, which explain the visual experiences, misperceptions and occasional hallucinations that people report under these drugs. Many reasons to think why psychedelics might have antidepressant properties. So they share certain effects with antidepressants, lithium, ketamine, etc., as far as they stimulate neural outgrowth, dendritic complexity. So they may be what's called psychoplastogens, stimulating neurogenesis. They also have interesting effects on circulating levels of cytokines that are also implicated in depression, such as 16 or 13, and in this case, tumor necrosis factor alpha brings into play an interesting discussion about whether they might be effective in low doses for inflammatory conditions like rheumatoid arthritis, but no one has explored that. Good for a trial though. But what happens in the brain is that it becomes deconstrained. So bits of the brain that don't normally talk to each other start talking to each other. That's represented by these two diagrams here, A under placebo, B under psilocybin. And around the circumference of these circles, you have different brain regions, and then the lines in between represent the degree of functional connectivity between them. So it's not that brain activity is increased. You might infer that from this slide. That's not what it's trying to say. What it's saying is that it's deconstrained. So there's increased crosstalk between regions, increased entropy, increased disorder in a sense. And this probably underpins this dream-like state that people report. And of course, one sees similar things in dreams. EEG changes, suppression of cortical alpha, for example, again seen in stages of sleep. And the question, again, is does this lead to a clinically useful state of temporary cognitive flexibility in which you can break down bad habits, perhaps challenge depressive cognitions, challenge the behaviours that mediate addictions or anorexia, or trauma response, or anxiety? Is that possible if the drugs are delivered in a safe, supported and trusting context and within an ongoing process of psychotherapy? That's the idea. That was the way they were used before. But we're kind of starting again. This is a UK psychiatrist called Ronald Sanderson, and he had a LSD psychotherapy centre in a hospital called Powick in Worcester, which is in the sort of Midlands in the UK. And he was interviewed in 2000, around 2000, and this is what he said. LSD does not behave like any drug in the pharmacopoeia, but the effect varies not only from one person to another, but in the same person on different occasions. It's not a drug in the specific sense of other remedies. I saw it as a tool for the promotion of psychotherapy, and I still maintain the same opinion. Today, when LSD is regarded by its protagonists as a recreational drug, it's difficult to understand the esoteric nature of this remarkable substance. Those of us who use this in clinical practice developed a reverence for its properties, rather as the shamans of old regarded their magical plants. There's so much in this statement that is interesting. Clearly, he was rather enamoured of LSD, and I think that that is a problem because obviously one brings that certain lack of objectivity into the room, but it also speaks to the fact that these drugs are special in inverted commas, not special, but need to be thought of in a different way. And they seem to make people sensitive to context, which may explain why they are useful tools in psychotherapy, or why they may be useful tools in psychotherapy. And what we're doing with LSD, what we were doing with LSD then, is broadly the same as what we're doing with psilocybin now, except for the caveat that all psilocybin, generally speaking, is given within a clinical trial at the moment, so therefore not controlled. I'm not going to go through this, just to say that there's a long history to the use of psychedelics in medicine. In the Western world's first descriptions were actually around 1899. Mescaline was actually the first thing synthesized. It was used sparingly, and it was LSD that came to be predominant, partly because it was developed by a pharmaceutical company, Sandoz, which is now part of Novartis, and it was marketed and given away for free as a sort of experimental agent. So that's part of the reason why LSD became so popular. And the same guy actually synthesized psilocybin as well, Albert Hoffman, again with Sandoz, and that was made available again under the brand name Psilocybin. Psychedelics then diffused out of the clinic, swept up in the war on drugs, particularly the Vietnam War and countercultural opposition to that, and subsequent to criminalization around the world, the research essentially stopped, and it's only in the last 20 years or so that this is slowly and with some care being picked up. These are two pictures of the bottles of psilocybin and LSD as they used to be available in the late 50s and early 60s, but subsequent to the UN Convention on Drugs in 1961 and then in 1971, a variety of national laws were passed, including the Controlled Substances Act in the US, and in the UK the Misuse of Drugs Act in 1971, and these placed psychedelics in Schedule 1. And what Schedule 1 defines is that the drugs are not prescribable by doctors. So at a stroke, all prescription for routine clinical purposes was stopped. I'm not going to go through this, I've kind of gone through this, but this was sort of part of the reason for that guillotine, if you like, legal guillotine, to control psychedelic drugs. But one wonders a bit whether it threw the baby out of the bathwater. Quite a sort of healthy research activity going on pre-Schedule 1, lots of clinical trials, patients being given the drug, and after Schedule 1, after criminalisation, that research petered out, and it's really only in the past 10 years or so that it's started to pick up again, coupled all in this paper I wrote recently. So basically we're starting again with psilocybin, but it's not the only one. S-ketamine is now available, and so a stigmatized drug of abuse. MDMA is actually further along than psilocybin and is going through phase 3 trials at the moment. And psilocybin, we are in phase 2, moving into phase 3. And of course we are asking the same questions that we ask of any new treatment. Is it safe relative to the disease that it's meant to treat, and is it effective or efficacious relative to placebo? It's a very expensive process, a very long-winded process, and these drugs may fail, and that's okay. If they do fail, then we'll try something else. But I do think it's important that they go through the same tests as any other drug, any other therapy, and I think it's important not to short-circuit that. So for the remainder of this talk, I'm going to concentrate on 2 trials. We started with a healthy volunteers trial here at King's. We started planning this back in 2017, started dosing 2018, finished in 2019, and then pandemic and publication stuff, which you all know, we finally published this paper 3 months ago. It's the largest ever randomized controlled trial of psilocybin published in the journal, and it's a healthy volunteers trial, and it was about safety and cognitive and emotional processing. So I'm going to tell you a bit about this. We dosed 89 healthy volunteers. We randomized them to receive a single dose of either placebo 10 milligrams or 25 milligrams of psilocybin, which the sponsor calls COMP360, but it's psilocybin. You can see the inclusion criteria there. It's not difficult to recruit people to this trial, as you can imagine. And this trial was used as a therapist training vehicle for the multi-centre international treatment-resistant depression trial that was completed last year by the same sponsor, in which I'll tell you about a little bit later. So, nearly 90 people randomised to placebo, 10 milligrams, 25 milligrams of psilocybin, given on a single dosing day with baseline observations and then data collection at day 1, day 7, day 28, and then the end of the study was day 84. Primary point of the study was one of safety, and also to look at the effects of single doses of psilocybin on cognitive and emotional processing. This was the setting that we gave the psilocybin in. The unique thing about the study was that we gave the psilocybin to more than one person at the same time. So in this picture, you can see 2 people who have been given psilocybin or placebo. There are 2 people behind them as well, and we gave up to 6 participants the drug simultaneously. No one's done that before. This is the recruitment process. So you can see how many we screened, how many we excluded, and there was not much dropout in the psilocybin arms, a bit of dropout in the placebo arms, and I suspect that that speaks to some degree about problems of blinding and expectancy in these trials, which I will also cover later on. This is the data that we collected. Essentially used a tool called the CAN-TAB, which is a well-established cognitive measurement tool. I'll take you through the tests that we use in a minute. Various other assessments I'm not going to tell you about today, don't have time, and then adverse events data. And these were the people, and the randomization process you see pretty equal between the groups. Slightly more males than females, that is often the case in drug trials. More people in this trial had previous psychedelic exposure than in the general population, so bear that in mind. Baseline rate of prior psychedelic experience is about 10 to 15% in the general population. Lifetime, in this study it was nearly 40%, so slightly unrepresentative sample. And you can see how many times we gave psilocybin to more than one person in the column on the bottom right. So gave it to 6 people on 2 occasions. The majority of sessions were given to 4 participants. These are the most common adverse events ordered by incidence in the 25 milligram psilocybin arm. You can also see the 10 milligram and the placebo group there. Some people under placebo report hallucinations, which is a known phenomenon, and then you can see the extent to which these different events were reported in the 2 groups. As you would expect, really, hallucinations, illusions, altered mood. Headache is common post psychedelic for reasons we're not entirely clear of, probably a serotonergic mechanism of action. Changes in moods, changes in the perception of time, etc., etc. The vast majority of these adverse events happened on the day and resolved on the day, and the majority of them also were psychedelic in nature. That is to say, they were considered a known effect of a psychedelic. The major message from this trial was that if we recorded an adverse event, it was very unlikely to persist, and for those that did persist, they were very unlikely to be attributable to psilocybin. So they were more sort of incidental things like colds or headaches or that sort of thing. So suggests that the safety profile for the drug is relatively good. We did a breakdown of mood-altered adverse events. 10% of these were 10% of AEs were coded in mood orders, and the vast majority of those were positive in nature by post hoc analysis, and 3.5% were rated as negative. So perhaps reassuring that psilocybin is at least not making healthy volunteers feel a lot worse, and maybe making them feel a bit better. But the headline is that there were no serious adverse events in this study, so nothing that we thought that was a serious threat to someone's health. And there were no adverse events in this trial that led to someone withdrawing from the trial. Lots of expected psychedelic effects, but most of these resolved by the next day, and the remaining were most usually positive. There was one instance of negative mood on psilocybin, 10 milligrams. This resolved in follow-up. So it's an unusual drug. It's obviously a very noticeable drug, but actually it seems relatively benign. It's fairly good clinical safety profile. I just sort of caveat that by saying, when I sign the prescriptions for these drugs, I don't particularly worry about them. I kind of worry more about prescribing someone olanzapine and the risk of sedation and falls and weight gain and metabolic syndrome. I don't really worry about prescribing people psilocybin, but that's not to say that risky things don't happen on occasion. But we didn't observe anything serious in this trial, and I'm sure we will do in future trials. And given enough time, serious stuff always happens, but of course that happens with drugs that we prescribe already. So this is the cognitive data. We focused on various measures of the CAMTAB. I'm going to show you little videos of the tests that people did. Should play. So this is a test of episodic memory, paired associates learning. You're shown a number of boxes with symbols, and then they're covered up and the symbols appear on the screen, and you have to remember which box contained which symbol. So that's a simple test of episodic memory. Spatial working memory task, essentially showing a series of boxes, some of which have yellow boxes in, and you have to fill up the column. Pretty easy test of working memory and executive function. Rapid visual processing is a measure of sustained attention, so you have to recognise that sequence 357 as it appears and then press the button, so you have to sustain your attention over time. Emotional recognition task, where you're showed briefly various faces and then have to say what emotion you see, and you're essentially timed on your reaction. And a planning task, the one-touch stockings of Cambridge, where you have to mimic the pattern you see at the top by moving the balls in the bottom. So you have to plan your moves to complete the puzzle. So. And finally, cognitive flexibility, the extra dimensional set shift. And here you just have to make a guess, and through feedback work out what the theme is. Here it's that funny building that looks like the Taj Mahal, but you only work that out over time, and you're tested on how quickly you work that out. And these are the results, and they're really not that interesting, so I'm going to whiz through them. We basically didn't find any negative or positive effect of either 25 milligrams or 10 milligrams of psilocybin when compared to placebo. People tend to get better at these tasks through practice effects, but there are no significant differences between the groups, and you can see that in these graphs here. So I'll just slowly cycle through these so you can see what's happening. This is a composite in which you essentially combine the scores for different tasks that measure similar things. Again, no significant differences between the groups. Possible that we were underpowered to detect a difference. This wasn't a priori powered as an exploratory study, but to be honest, the data looks as though there isn't much difference, and clinically I don't really know why you would expect to see a big difference between placebo and single doses of a psychedelic drug. Not like they're magic. The one thing that I thought was a bit interesting was this slightly dose-dependent effect on emotional recognition. You can see SIBO at 25 milligrams.
Well done.
The reason why that's interesting is because other groups have observed that people under the influence of psychedelics and after psychedelics become more emotionally responsive. So it's possible that we were seeing this phenomenon here, but again, it was not statistically different, significantly different between the groups. So maybe underpowered, or maybe that there is no significant effect, or no significant effect here with the planning task. So no statistically significant changes, and the basic conclusion is that this drug seems to be relatively safe for delivery in a clinical trial setting and doesn't cause harmful changes in cognitive function, say its treatment of depression. So that allows us really a decent basis to go on to trials in patients, and that's what I'm going to tell you about now. The caveat here is that this, the results I'm going to show you have not been peer-reviewed and not been published yet. They've just been released, top-line data by the sponsor last year. But this was a very large, multi-centre international trial of psilocybin therapy for treatment-resistant depression that we were principal centre of here in the UK, and which we trained the therapists for in the previous trial that I showed you. These are compasses, the sponsor's slides. Again, COMP360 is psilocybin. And essentially what we're testing here is whether people with treatment-resistant depression who are withdrawn from their antidepressants and given a package of psychological support, we're testing the difference between 3 doses of psilocybin, 1 milligram, 10 milligrams, and 25 milligrams. And this is the way the study proceeded. At 20 sites around the world, people were screened. The study team got to know them. They were introduced to the psychotherapists who engaged with them. And they were withdrawn from their antidepressants over a 3 to 6 week period prior to baseline. They were then randomised to receive 1 or 10 or 25 milligrams of psilocybin, along with psychological support delivered in a similar setting to the picture I showed you earlier, though differently to that, they were given them, they weren't given this in groups, they were given this just with their therapists one by one. And then they were followed up day 2, week 1, week 2, week 3, and finally week 12 with some remote visits in between. And a package of psychological support was given during that time. Therapists were available for psychotherapy at those times and also in between times if necessary. So again, testing this idea of drug-catalyzed psychotherapy, but in this context, the only difference between the groups is the dose of psilocybin. And the primary endpoint is essentially to determine, disambiguate between the 10 milligram and the 25 milligram doses in terms of efficacy and safety. So here are the people who were randomised and the number who discontinued, roughly equivalent between the groups. In this study, 94% had no prior psilocybin experience, so much closer to the population demographic of previous psilocybin use. In fact, slightly less. So hopefully a slightly more representative sample. And this was a primary outcome, the Montgomery-Åsberg Depression Rating Scale, well accepted, well validated, clinician-administered measurement of depression. The important thing to understand about this is that the teams did not collect the outcome measure. This was done by blinded, independent, geographically remote raters over the telephone. So we have no involvement at all in the collection of the primary outcome, which hopefully mitigates some of the concerns around blinding of clinicians. And you can see the difference here between the 3 groups along the trajectory of follow-up. So you can see a rapid effect on MADRS scores in all groups, but statistically significantly different between the 25 milligram group and 1 milligram group. and this is sustained up until week 6, when it becomes non-statistically significant. These are the people who respond on the MADRS, where response is a 50% decrease in MADRS over the different time periods and within the different groups. And what you can see is a response rate of about 50% versus 22% in the 25 milligram and 1 milligram groups respectively, and you can see this response rate tapering off over time, and then this curious rebound at the end of week 12, which I suspect we need to treat with a pinch of salt, because you'd probably be expecting it to be roughly the same between groups rather than that. I'm not quite sure what that's about. So kind of what we'd expect really from a single dose of a drug, that it has an effect but then it starts to wear off. But interesting that it's sustained for this length of time. And similar picture seen for remission, so a MADRS total score of less than 10. You see less people remit than respond, but you can see the difference between the groups there, and again, a slightly curious artifact at the end, which maybe is a good end of study artifact. But for a treatment-resistant group, these are people who had failed a minimum of 2 and a maximum of 4 antidepressants. Still some encouraging signs of efficacy here. These are the sustained responders at week 12, so people who met the MADRS response criteria at week 3 and week 12, and at least one of the visits at week 6 and 9, and who didn't start any new treatments for their depression. Only about a quarter of people in this group, but perhaps that's what you would expect in a population who are this treatment resistant and unwell. And safety signs, you can see this is having a similar adverse event profile to the healthy volunteer study, but what we were interested in was the serious adverse events. These were comparable between the 10 and 25 milligram group, but I think what's important to understand is that there were more serious adverse events in the groups that received the higher doses of psilocybin. That needs to be thought about carefully in the context of whether these drugs are a bit of a gamble. There was a suicide in this study. I think there were suicide attempts in the study. It wasn't significantly different between the group, but obviously we need to keep an eye on this and study each case very carefully indeed to understand what's happening. And these are the adverse events that were recorded, again similar to what you saw before. In this study we weren't recording things like hallucinations because they were known effects by that time of the drugs, so we had to record those as adverse events. And again, headache, very common in those people given psilocybin. Usually responds to simple treatment with acetaminophen, ibuprofen, that sort of thing. And then adverse events really as we would expect in this sort of study. These are the serious adverse events. 3 instances of suicidal behaviour in the 25 milligram group. I'll talk a little bit about that later, whether it's a direct effect of the drug or whether it's a sort of disappointment effect with knowing that you've got the drug and it not working, and then other issues, as you can see down the left hand side there. So this was the largest ever psilocybin therapy trial by far. The largest prior to this was an N=60 study that took place here in London, but just caveat, it's not been peer reviewed and published yet, so take these results with a pinch of salt. I thought the results of this were quite reassuring. They were worse than the sort of ridiculous effect sizes that we were seeing in the early phase 2 trials in single centres, but that's what you'd expect, regression to the mean. So in many ways I thought that was quite reassuring. This is not a miracle panacea, but it may, but there is some sign of efficacy, and we should proceed on to phase 3, I think, but with a mind to the safety signals that we see. I'm not sure what time it is and how much time I've got left. Oh, 1:45. Okay. So next steps, we will probably start phase 3 trials. When they said Q3 2022, I think that's probably quite optimistic, to be honest, but I suspect probably next year. And that will be a sort of similar pipeline of provision that we gave in the phase 2B trial. And all of this done in liaison with FDA, US, MHRA, UK, EMA and Europe to make a final decision about whether this drug is safe and effective, whether this drug-assisted therapy is safe and effective. And for the rest of the talk, I just want to talk about some of the problems with these trials, because there are many. Of course, there's no perfect trial, there never will be. And trials of psychoactive drugs are particularly problematic. Of course, many of the issues I'm going to talk about apply to antidepressants, where people can tell that they're on them, antipsychotics, etc. But I think probably particularly pertinent in psychedelic trials, particularly given the sort of cultural baggage that they tend to bring with them. Okay, so the most obvious one, when you think about blinding and expectancy, it just isn't possible to blind people from receiving a psychedelic unless you gave it to them under an anaesthetic or something like that, which probably wouldn't be ethical. So given that these trials tend to attract people with positive expectations about psilocybin therapy, we can't force people to enter into trials. We have to take people who volunteer, and they are likely to be biased in favour of psilocybin, and because we can't effectively blind, that is likely to bias the data in favour of psilocybin therapy. Similar problems, as I say, we've seen with most psychoactive drug trials, and this is one of the reasons why the antidepressant efficacy wars rage on Twitter. Of course, it applies to many other forms of treatment. You can't blind surgical interventions, you can't blind psychotherapy. Does this mean we shouldn't do the trials? I would say not, so I would disagree. Just to re-emphasise this point, everyone in these trials got psychological support. We know psychological support is effective in the treatment of depression, and the idea for the real world is that psilocybin therapy is a drug-assisted psychotherapy. So what you're seeing in these trials is just the difference between the different doses of the drug, not the differences between psychotherapy, because everyone gets psychotherapy. But what that suggests is that the real world efficacy may actually be better, because everyone will be getting psychotherapy. So better compared to not getting anything at all, although that is obviously going to be dependent on there being decent psychotherapists and enough of them to deliver this. There's an awful lot of hype and hyperbole around psychedelics at the moment. I think this causes a lot of problems. The media jump on the bandwagon. This fuels investor confidence. You get this sort of cycle of hype, and this creates bias in people who volunteer for the trial too. It probably creates bias in people who are collecting outcome data, and in the trial teams. Again, something that biases the data in favour of psilocybin. Of course, this is seen, similar phenomena is seen with other drugs. This happened with Prozac to an extent in the 80s. Probably not to the same extent as this, though. It's really unclear what can be done about it if we continue with this model of commercial investment being needed for treatment development. Hitherto, governments have delegated the process of treatment development to pharmaceutical industries. They are profit motivated, and they need investors. So that's the nature of the beast. Unless we entirely change society and government starts funding drug development, which it probably should, to be honest, but that's not the way it is. That's the way it's going to be. But we need to consider that, of course. Just thinking about safety data, I mentioned this already. It could be that suicidal behaviour is a direct adverse effect of psilocybin. From my knowledge of the narrative of the serious adverse effects that happened in this trial, I'd say it's more likely to be route 2, which is that if the drug doesn't work and you've come with a lot of positive expectation and are quite desperate, it's very disappointing, and this then compounds your depression, and you're more likely to then to behave in a way that's classified as a serious adverse event. Can't rule out, of course, the possibility of a direct adverse drug effect, but that wasn't really the narrative that I observed in the trials. But, you know, all of these problems with trials, that's just the start. Let's just assume that it's approved. I think that opens up a whole new raft of questions. I suppose maybe in some way interrogated by what Oregon is doing. Who gatekeeps this treatment? Who pays for this treatment? It's likely to be expensive relative to other treatments. Who delivers it? We're going to need armies of carefully regulated psychotherapists, psychiatrists who understand. And using what infrastructure? We have a very drug-focused model of delivery of mental health care thus far, but this is different. This is a different paradigm. People need to come into a facility to have their experience, to have ongoing psychotherapy. Where's the infrastructure for that? I think probably we can modify existing mental health infrastructure, but that's going to take time and money. And then how to regulate it, how to keep the quality, how to maintain safety. And this is a key issue. And some of you may have come across a podcast recently called Cover Story, which covers narratives of really horrendous abuse in the underground psychedelic therapy world that happened around the world, but then also covers concerns that this has happened in clinical trials as well. Something about these drugs obviously putting people into vulnerable states. We need to be exquisitely careful that safety, oversight and regulation are maintained if this is going to be a sustainable treatment. And yet at the same time you have articles like this. This is the guy who heads the Multidisciplinary Association of Psychedelic Studies that funds the trials of MDMA assisted psychotherapy for PTSD that are now in phase 3, and he writes articles with titles like this. And I don't agree. We need to keep equipoise. Equipoise is so important here, and it's at risk of being lost. So I'm trying to do this the right way, and if it fails, I don't mind. I'll go and research something else. My interest is in the patients and therapy and the drugs and how they work. This is what we're doing at King's, a variety of different trials in various stages of development. This is what next for us, phase 3 trials of economic analyses to see whether this is a cost-effective treatment. And the critical question, I think, is whether we can add psilocybin therapy to an SSRI. At the moment we take people off their antidepressants, that may not be necessary. Lots of other interesting questions to ask with these drugs, which I won't go through now. So this is my take-home message: beware evangelism, but beware demonization as well. Stick to the science. Hopefully the data will speak for itself. Quick summary, what we talked about, these are the lovely people who undertake this work here at King's, but there are many such groups around the world, including in the US. I'll stop there. Some time for questions. Thank you very much for your attention.
Thank you so much, Dr. Rucker. Very stimulating and interesting discussion here. And I invite our attendees to post questions in the chat. I'll get to them as you post them. We've got a few minutes here. A few questions that have come through, Dr. Rucker. First is just simply when psilocybin or psychedelic therapy does work for reducing depression-associated scores, why do you think that's happening? What is it about this experience that is resulting in a sustained improvement in depression?
So many ways of thinking about that. You could think about it from a biological perspective, that it's stimulating the glutamate surge in the prefrontal cortex that is stimulating neurogenesis in regions that are related to depression, and that's the reason why people get better. I tend to think of it more in terms of subjective experience and what people can take away from that experience. So Johns Hopkins team correlated the extent to which people had a mystical experience with sustained improvements from psilocybin therapy. That in a sense, that sort of makes sense to me insofar as a lot of the people I see with depression, they seem to have lost their sense of faith, they lost their sense of connection to themselves. Maybe the mystical experience is about the redevelopment of a connection to the self, or the redevelopment of a connection to something else that forms a foundation of your sense of mental well-being. I think there's something very interesting there, and I probably would lean towards that as a narrative that most people could attach to and understand. There's a reason why single doses of a drug may lead to long-term improvements in mental health. It essentially sows a psychological seed that you take away with you, and depending on the ongoing psychotherapy in the context of your life, that can grow. That would be the way I think.
On a similar line, what does the data show us in terms of the longest treatment effect that we've seen? So say somebody does have a positive response early on, do we have, what's the longest we know of a sustained improvement?
Well, so some people in the early phase trials I was involved with at Imperial received 2 doses of psilocybin therapy and were highly treatment resistant, and have been well ever since, according to them. Of course, that's sort of non-objective, and I don't know about the people who report the reverse. But there are some people who seem to have very, very sustained remission from depressive symptoms, and a couple of people that I'm thinking about from that trial have been on 10 different antidepressants, had years of psychotherapy. Something happened in those sessions that just shifted their perspective away from this very depressive, habitual mindset of bleakness and fearing the world and other people and themselves terrible. But also there was this strong psychological element of I'm being given this new amazing thing, that they say is going to cure me. So I think there's something strongly context dependent about that specific trial and the improvements that those specific people had. Whether or not that happens in the multi-centre trials, we will see, because there's a long-term follow-up trial that's currently completing at the moment.
And can you give us a sense, just in a practical sense, if somebody was going to, let's say this gets approved, and we're expecting next year these treatment clinics or facilities to be set up, whatever that's going to look like. What is the how long does a treatment session last in a given session, and then what is the expected number of sessions a person would go through?
Yeah, so as I say, it's at the moment we're testing single doses, and that was a sort of decision based upon the sort of stigma and safety concerns around the drug. But the idea is that this would be a process of drug-assisted psychotherapy in which you'd have a number of sessions embedded in an ongoing process of psychotherapy. And I think that the data probably suggests, given that the effect seems to wear off after about 6 weeks, that that's the sort of time period you should be thinking about in terms of space between different sessions. But I think it needs to be considered on an individual basis. I don't think it's useful to think of this as a one experience and you're cured. That's just completely unrealistic from my perspective. The clinical trials process has to be very regimented, and you have to say exactly what you're going to do. I think if the drug gets through approval, if the therapy gets through approval, then we can start to think about how to deliver it in a way that's more flexible to people's needs.
And within a treatment session, how long does that usually last? Somebody receives a dose, and then how long are they, on that couch, seeing dreams?
Yeah, sorry, I forgot that bit of the question. So it's a day hospital treatment. So you come in the morning. We usually dose around 9:30, 10 o'clock, and it's over by 5:36. So it's not quite 9 to 5. It's more like a sort of 12-hour shift when all's said and done. But it's deliverable. You don't have to keep people overnight, which is important to them in terms of thinking about costs.
And is that usually the duration of the psychedelic experience? Are people having is it 8 hours or so? Is that a typical duration of hallucinations or whatever kind of experiences they're having?
I usually find the effects, they come on after about half an hour, They then sort of ramp up over the course of the next hour. They then are most intense for 90 minutes after that, and then they fade away over the course of the next 3 to 4 hours.
Okay. And last question here. So you mentioned expectations, and people tend to get a benefit from things they believe in, and it looked like in those I think that phase 1 part of Compass, about 30% of patients had a prior psychedelic experience. Any thoughts on what effect or benefit might be in somebody who has a very negative perception of drugs and controlled substances like this? How much of this do you think really is that set mindset of believing this will work versus truly a benefit?
Yeah, I don't know. I mean, I believe in the power of belief, and I think every doctor and every psychiatrist uses this every day to try and find treatments that fit for different people. If you're a priori against psychedelics, why on earth would you have psilocybin therapy? It just seems ridiculous. On the other hand, what I tend to find is that people who are anti-SSRIs tend not to be so anti-psilocybin, and that's about the cultural origins of the drugs. So it's like what I said, it's having strings to our therapeutic bows to offer people. As to the relative role of set and setting, I'm sure it's impossible to disambiguate. It's all of this. I tend to think of psychedelics like super placebos. They moderate the cognitive mechanisms that generate expectancy themselves. So in that context, if you're trying to separate them out and establish what's expectancy, what's drug, you'll never do it because it's in there.
Yeah. Well, Dr. Rucker, thank you so much for this very stimulating talk again, and thank you for. We'll allow you to get to your dinner as we're about to go to our breakfast, and glad that we could make this connection work across the ocean, and continue the good and important work you're doing in this interesting field of research.
Thanks very much, Jesse, and pleasure to speak to you. Have a good day.
You as well, and take care, the rest of you. We'll be off for spring break next week, and we'll resume on the 29th for a talk on palliative care. Look forward to seeing you then. Bye-bye.